Let's have a quick discussion about metabolic alkalosis. So it can be caused by several different things. We're going to focus on shifts, and we're going to focus on what happened in our patient with GI loss, and we're going to have a brief discussion on post-hypercapnic alkalosis. The other causes include renal loss, us giving them bicarb, and volume contraction around a fixed concentration of bicarb. Okay, let's talk about what's going on here. So stomach, this is the stomach. We have a bunch of HCl in the stomach, and this patient's vomiting out copious amounts of this HCl. Hydrogen ion H plus is derived from H2O, and H2O dissociates and you get H, and you get this hydroxyl group. So if we lose H, like in this case, we're losing H over here. If we lose it, we're left with this hydroxyl group. The hydroxyl group has to do something. It binds with CO2 and it forms bicarb. So a metabolic alkalosis is increased bicarb. That's what we're showing here, and that is equivalent to loss of H+. So metabolic alkalosis is equal to increased bicarb, which is equal to decreased H+. Now, in most patients with vomiting and normal renal function, the kidneys will simply compensate by secreting bicarb. So this image is what would happen in all of us if we weren't particularly dehydrated or had some other issues going on. We would simply secrete this extra bicarb and we wouldn't develop the alkalosis. However, patients with the volume contracted state is the most common reason. There are others. The kidney loses its ability to secrete bicarb, so the kidney's not functioning well. So we don't have this to balance this increase of this, and therefore we'll get the metabolic alkalosis. Okay, so that's what's going on in this patient. Now, this of course is a little more complex. This patient almost certainly would have had ketones and had a tendency toward ketoacidosis. This patient was dehydrated, and when it's really profound, we can have ischemia potentially, and we can develop a lactic acidosis. So there are lots of things that are in play in patients like this. But in this particular case, the way this played out, the loss of HCl through the stomach and the subsequent increase in bicarb sort of trumped everything else, and the patient developed the metabolic alkalosis. So let's talk about shifts. So that was GI loss. Let's talk about shifts now. So potassium is the major intracellular cation, and it's present in a much smaller amount extracellularly. The body tightly regulates this extracellular amount though. So if you have hypokalemia from diuretic use, for example, or other renal loss or GI loss, and you lose this extracellular K+, this extracellular potassium, what will happen is the intracellular stores will move extracellularly. So this K+ will come out extracellularly to try to keep this concentration adequate. Now, anytime something crosses a cellular membrane, something has to go back the other way of the same charge. So some sodium goes back, but H+ goes back. And so H+ will move in response to the K moving out. And so if H+ goes in, we just talked, that's equivalent to an increase, or if we lose H+ here, that's going to be an equivalent to gaining bicarb here in the extracellular space. So you'll get a metabolic alkalosis. And so the way I look at potassium, it can either be it's like a chicken or egg. So they're really intimately related, potassium and H+. So if hypokalemia is the primary problem, you're going to have exactly what I've just drawn out here. The K+ is going to go out to compensate, H+ is going to move in, and that's going to result in maintenance of this, but it's going to result in accumulation of bicarb extracellularly, and you'll get a metabolic alkalosis. If you get an acidosis, so all of a sudden you have a whole bunch of H+ extracellularly, well, the body does try to control that somewhat, so they'll move some of that H+ intracellularly, and when that happens, K+ has to move back out. So you may actually see hyperkalemia in the setting of a metabolic acidosis, and we see that all the time in DKA. right? Their total body and potassium stores are generally not high, but they're initially, when they come in, their serum potassium is often high. And that's because of what's happening right here. That patient's quite acidemic, so they take all that extra H+, move it intracellularly, something has to come out, so the K+ comes out. On the other side, if we have a primary metabolic alkalosis, then H+ is actually going to go out this way. It's going to come out this way. To try, again, we got a metabolic alkalosis, so we have a low H+ extracellularly, so the body will move some H+ out, something has to move back in, and that's the K. So the K, so you'll get hypokalemia out here. So hypokalemia can cause a metabolic alkalosis, and hypokalemia can result from a metabolic alkalosis. All right, let's go on and talk about the final thing, which is this PostHypercatnik metabolic alkalosis. So you guys have seen these tables before. These are our blood gas compensation tables that we use. So if we have a patient with COPD, they've had COPD for 15 years and it's just gradually getting worse, and they've got a chronic respiratory acidosis, right? We see patients walking around with PaCO2s that are really high. What does the body do to compensate? Well, our third column here tells us it increases the bicarb, right? So the kidneys hang on to bicarb, produce bicarb to try to get that pH to trend back toward normal. If it didn't do that, this PaCO2 of 80 or 90 that this patient's walking around with would result in a very low pH. But the patient retains bicarb, and how much it retains, or what the new level of bicarb will be, is dictated by this formula here. But the bicarb goes up. So what happens if you have to intubate a patient with COPD? And let's say they're actually not in a COPD exacerbation, they've got a bad head injury or something, and they get intubated for that reason. It's very important to look at some baseline blood work and have an idea of what you're trying to do with your mechanical ventilation. Because what can happen is we can harden these patients in that if we shoot for a normal PCO, if we don't know they're a chronic CO2 retainer, and that they therefore have chronic elevation in their serum bicarb, and we shoot for a normal CO2, the kidneys do not compensate fast enough to get rid of this bicarb. So all you're going to be left with is this high bicarb. And patients will often have bicarbs in the 40s when they're compensating for their chronic respiratory acidosis. So if that head injured patient who has baseline COPD and has a CO2 of, I'm just pulling numbers here, we'd have to do the math to get exact numbers, but has a PaCO2 of 80 and their bicarb normally is 40, and all of a sudden we shoot and get a PaCO2 of 40, they're still left with a bicarb of 40. So therefore they're going to have a pretty significant metabolic alkalosis as a result, and that's post-hypercapnic metabolic alkalosis. So just back to the first slide, summary. In our patient, we've got this as the cause for the metabolic alkalosis, transcellular shifts, and how H+ and K+ are very much related. We didn't specifically talk about these, but these are other causes. And finally, we did specifically talk about this. Thanks, everybody.